Sir, please start. Thank you. Kindly unmute yourself. Sandeep, sir? Yes, thank you.
Good evening, everyone. Welcome you all. Myself, Dr. Sandeep Karle from Parvani. I am the Executive Board Member of Maharashtra IP 2026. Welcome you all for today's Young Voices Expert Wisdom session, episode 2. Before starting the session, I welcome, first of all the delegates as well as all the office bearers of Maharashtra IP, our President Dr. Sanjay Joshi sir, Vice President Dr. Amol Pawar sir, immediate past President Ronu Boronkar Madam Secretary, Dr. Sagar Bhalerao, Dr. Mahesh Ahir Rao sir, and other EVs. Similarly, I also welcome today's all the experts and speakers. Expert respected Dr. Sunil Godbole sir, and our speakers Sarika Gaikwad madam, Dr. Meenakshi Ferwai madam, as well as Smita Bajaj madam. In today's era of mobile, internet, digital environment, with smaller families, more of urbanization, developmental issues and problems related to the neurodevelopment are increasing day by days, and they are more or equal important now than infectious diseases problems. That's why our committee of experts from Maharashtra IP scientific committee, which includes Dr. Sanjay Nathu sir, Bela Verma madam, Prashant Jadhav sir, Godbole sir, all have decided to include all these developmental issues and neurodevelopmental topics. And that's why today we are going to discuss all these topics for today's session. So before proceeding further for the actual scientific session, I request our President, Dr. Sanjay Joshi sir, to please give welcome speech to all the audience.
Namaskar. Am I audible?
Yes, sir.
रामनवमीच्या या पवित्र पर्वाच्या समस्त आमचे महाराष्ट्र आय पीचे ओबीज ईबीज today's expert Dr. Sunil sir and our 3 young ladies and also the virtual attendees यांना रामनवमीच्या खूप खूप शुभेच्छा. डेव्हलपमेंटल ही थीम ठेवण्यामध्ये मला वाटते प्रवीण आय मस्ट कॉंग्रॅच्युलेट यू on this auspicious day of Ramayana, because Ramayana, when we read Ramayana, we hear Ramayana, we know how the development of the child should be, what should be the ideal nurturing practices, what should be the ideal ways of rearing the kids and upbringing, their upbringing. The Ramayana is one of the best example of the most idealistic upbringing of the kids. आणि प्रवीण तू याच दिवशी ही थीम निवडली. आय रिअली कॉंग्रॅच्युलेट द यंग व्हॉइस टीम. मित्रांनो, आजचा टॉपिक इज व्हेरी क्लोज टू माय हार्ट. अर्ली डिटेक्शन ऑफ ऑटिझम. इट कॅन मेक रिअली वंडर्स इफ इट इज नॉट अ जेनेटिक or it is not part of a syndromic thing. Another thing is the screen time. Myself and our entire Maharashtra IP team are going to put our very strong words to the government that there should be no screen below 5 years. And we will definitely meet the lawmakers for this issue. And of course, the third is the issue related to cerebral palsy. So very right choice of the topics. So the most important part is गोडबोले सरांचे खूप खूप आभार. त्यांनी इथे एक्सपर्ट म्हणून यायला संमती दिली. धन्यवाद सर. आणि आपल्या तिन्ही यंग लेडीज, I'm really, I'm not like surprised to see the developmental pediatric is dominated by Nari Shakti. I really good thing. I really appreciate all of you, and all of you are going to make a huge impact on this topic. So happy learning. I am signing off since I had to moderate a session on another platform. Thank you all. Thank you, the Young Voice team, Praveen, Sandeep, and everyone. Thank you, Renut. Thank you, other OBs and EBs. Thank you all. Bye.
Thank you, sir.
Bye.
Thank you, Sanju sir, for your kind words. Now I request Amol Pawar sir, if Amol Pawar sir is available.
Dr.
Amol
Amol
Pawar.
Pawar is traveling, and he has
Okay.
conveyed to me to convey his best wishes for the program
Okay,
on his behalf. So I think Dr. Sandeep, we can move ahead to Dr. Renu for her
Yeah,
words.
yeah. I request Renu madam to address the
Yeah,
gathering.
Jai Shri Ram.
Shri Ram.
As today is our auspicious day of Shri Ram Navami, it is a very pious day. We all know that. So on this occasion, the second episode of this Young Voices and Expert Wisdom's Expert. So we have the three young dynamic young voices in the form of Dr. Sarika Gaikwad, Dr. Smita Bajaj, who are the developmental pediatricians, and plus their own designation that will be seen in the CVs, upcoming CVs, and also Meenakshi Ferwani, who is the interventional therapist that is much needed for this. Previously, we used to have patients coming to us of CP where they used to tell, "नहीं आपोआपच चालायला लागे, आपोआपच," but they don't know or understand the importance of the therapy that is needed, that is in the form of the physiotherapy and the other interventional therapies, it's like stimulation, etc. And for a long time. So that is what the convincing of a pediatrician and sending them to a therapist is very important. And to carrying it out further by the parents at home is also much important, rather than believing that अपने आप वो चलने लगेगा. And the topics today which are very most important, that is screen time and the developmental delay, it has been proved many times. And again, we are going to hear from Dr. Smita also, who is my friend from Chhatrapati Sambhajinagar. So also Dr. Sarika is going to talk on the autism part, and we know that the autism day is upcoming in the next few days. So we have this theme like that. And I appreciate Dr. Sandeep Karle sir, who is a senior pediatrician from Parbhani, and he has a very great work in hematology also over there, and in thalassemia. Am I right, sir?
Yes, yes, ma'am.
So he has done a great job of coordinating all this today's activity along with Dr. Praveen Gokhale sir, who is the EB member of CIAP and also advisor of our team and selecting the topic and the speakers. And Dr. Sunil Godbole sir, नमस्कार तुम्हाला. खूप दिवसांनी आपली भेट झाली व्हर्च्युअल प्लॅटफॉर्म वरती. So I have heard you many times, and it is very real great pleasure to hear you always. And the expert comments that you will give, I know that it will be a takeaway messages for all. So over to you, Dr. Karle, and thank you all the attendees who are there today on this virtual platform. Thank you so much.
So thank you, Renu ma'am, for the kind words. I request Sagar Balerao sir, our Secretary Admin, Maharashtra IP. You can address the audience.
Good evening, everyone. Happy Ram Navami and Happy New Year, and all the best, team IIP. I'll keep my things short. And today's important topic is young voice expert wisdom. It's a very important topic, and we are eager to.
Thank you, Sagar sir. Now let us start our scientific session. So before starting, I request our host to start CV slide sharing. Today we have got three speakers and senior expert, Dr. Sunil Godbole, sir. So Dr. Sunil Godbole, sir, is a developmental pediatrician. Sir is basically head of department at Dinanath Mangeshkar Hospital, Pune. He is a head of department for Child Developmental Center as well as Autism Center. He has his own Chiranju Center for Child Development and Diet. He has basically associate editor of IAP textbook of Growth Development and Behavioral Pediatrics released in 2024. He was a national chairperson of IAP chapter of Growth and Development for 24 and 25. He is a course director for PG Diploma in Management of Autism, and he was a faculty for IAP's Action Plan program from Cradle to Crayons and Beyond Basics of Behavior. So basically, he is a very senior expert, developmental pediatrician. He is author to 9 educational books as well as many, like more than 500 articles in newspaper, workshops for the parents, patients, doctors. So he has been trained in Germany also. So basically, very senior and expert we have got today. We are lucky to hear Sunil Godbole, sir. Then our first speaker is Dr. Sarika Gaikwad, madam. She is a developmental and adolescent pediatrician. She is from Wardha, basically. She is working as associate professor in Department of Pediatrics at Jawaharlal Nehru Medical College, Savangi. She has her own Growing Mind, the Child Development Center, which has got branches at Wardha, Hinganghat, as well as Evalmar. She has also taken multiple sessions for the patients, doctors. She is a very good speaker, counselor, as well as behavioral therapist for developmental issues in pediatrics. Then our next speaker is Dr. Smita Bajaj, madam. She is currently associate professor and unit in charge, working as in child guidance clinic in Government Medical College, Chhatrapati Sambhaji Nagar. She has done MD pediatrics as well as postgraduate diploma in developmental neurology from Kerala University. She is a MUHS recognized undergraduate as well as postgraduate teacher. She has received Best Paper Award for role of zinc in supplementation as an adjuvant to standard therapy in nephrotic syndrome at Mahapedicon 23. She has done advanced course in medical education, and she is also a medical accredited faculty. So she has also given multiple talks, and she has more than 20 publications in national international journal. So she is also a very learned, experienced, and dynamic developmental pediatrician from Marathwada area. And, our third speaker is Meenakshi Ferwani, madam. Currently, she is working as head of Department of Physical Medicine and Rehabilitation Center at MRR Children's Hospital, Thane. She has got international certificate in neurodevelopmental treatment, aqua therapy, as well as newborn assessment. She has worked at multiple institutions at Mumbai, Qatar, as well as London. And right now, she has got long experience of 17 years in pediatric rehabilitation. So, where we have got really very good person from rehabilitation part. So, welcome. I welcome all the three speakers as well as our expert, Godbole sir. So, now let us start our actual scientific activity. So, I first invite Sarika Gaikwad, madam. She is going to talk on early identification of autism in toddlers from 18 to 24 months. So I request Sarika Gaikwad, madam, you can now share the screen and you can start your scientific presentation.
Thank you so much. Good evening, everyone, all the seniors, gurus, and everyone. First of all, I give thanks to Maha IAP for providing me this an opportunity to present talk on this topic. Is my screen visible?
Yes,
Yeah.
make it full screen.
Yes. So today's topic is early identification of autism in a toddler, that is 18 to 30 months. So first we'll discuss about what exactly is the autism spectrum disorder. So we all know that it's a neurodevelopmental and behavioral disorder of childhood which is characterized by the impairment in a social communication, repetitive behavior, and age inappropriate abilities. So the children may have a severe disability, or some of the children with ranging from the average disability, average ability to extreme abilities also, but they lack in the social interaction, communication, emotional, cognition, and an adaptive functioning. So why this screening of autism spectrum disorder is important? As we all know, the prevalence of the autism spectrum has been increasing from 1 in 100 to nowadays 1 in 59 also. That is a 1.7% of the population, whereas the DSM-5 criteria also suggests the 1% of the population has the ASD. So first discuss about basic of DSM criteria 5, that is impairment in a social communication and interaction, whereas the other important point is a restrictive repetitive pattern of behavior. So in the first, the child will have a deficit in the social emotional reciprocity. So what do you understand by the emotional reciprocity is the ability to engage with the other and share the thoughts and feelings. So in communication, the intent to communication is very important. That you can see in the first side, the child is having good eye contact, the social smile is there, and the child is interested in the mother talk. Whereas in others photo, you can see that the child is not interested, doesn't have a good eye contact, and list for the communication purpose. Whereas the second point is there is a deficit in a non-verbal communication and use for the social interaction. As we all know, most of the pediatrician will get the children who are coming with a speech delay. So the first possibility of the speech delay, we always do a hearing screening just to rule out the deaf mutism child. So in a cases of the deaf mute child, the child will use a gesture as a non-verbal communication. But in a case of ASD spectrum, the child will not able to understand the non-verbal communication and doesn't do a pointing also. Third important point is they have a deficit in developing, maintaining, and understanding the relation. They prefers to have a solitary play, or they doesn't mix with the other children or to mingle with the other children. So V1 of this child will have the stereotype or repetitive motor movement. So what do you understand by the motor movement? They will have a hand clapping, the head movement, they will have the truncal movement, or they will just have the lining of object and use of object in a different way. So not only the motor component, they will have the repetition of the words or the verbal also, like echolalia. If a child, if mother will ask like की तुला जेवायचंय का, तर प्रश्नाचं उत्तर हो किंवा नाही मध्ये येण्यापेक्षा the child will answer in a sense की तुला जेवायचंय का. So this is a classical of echolalia. Here is, I can see videos of a child. You can see that the child is just doing a side posturing, the hand movement is there. This is a form of a motor movement. Here, even in this children, you can see that the child is, in this child, you can see that the child is doing a hand clapping movement. The child is excited to after watching something, and just the child is having hand clapping repeatedly. So the second important point in the autism children will be an insistence on the sameness or inflexible adherence to the routine. Like you can see that these children they resist a lot in any change in routine, to the extent they will have an emotional meltdown. As we can see that the summer vacation will be coming, these children will have a difficult to change their routine. So B3 will be having a highly restricted or the fixated interest that are abnormal intensity of focus. So if you feel that the child is liking dinosaur, will have everything possible with a dinosaur. Like for example, they will have a water bottle with photo with a dinosaur, t-shirts, tiffin, and the bags which are suggestive of this. This is a photograph of a child who has referred recently to me. That's a 7-year-old child who referred from a school that with complaint of child is not able to mingle with the school age appropriate children. When I asked the mother did not found any classical complaint, as the child is extremely intelligent and child has communication. When you just look through all the workbook of the child, you can see that the child just had drawn all the forms of all the circular object. Like the child is very obsessed with the speedometer, the watches, and all the things. So in every notebook, the child is present with this type of structure. Then the B4 is the child will have a hyper or hyporeactivity to sensory input, that is hypersensitivity to noise, the smell sensor, the texture sensor, the tactile issue. The child will have a hypo or hyper responsiveness video. So here is a video which you can see that in this child, the child is just obsessed with the self-image. He's just looking at the reflection of his own, and he's persistently doing the same thing. Even in the second Second video, you can see that this is a 4.5-year-old child. Child is doing just mouthing. So the mouthing usually stop around one year of a child. In this child, you can see that the mouthing is persistent, and the child is just having ability to do anything in the object in the mouth. So here, these are the visual seeking patients. So you can see that the child is just having looking at the object with very near to a object. Then there are certain red flag signs which we can use and which we can use with the help of the for early identification of ASD. That by 6 months, the child has to achieve the social smile and a good eye contact. If there is no social smile and no eye contact, you can suspect the ASD. By 9 months, the child should have a response to name. Lack of back and forth interaction will be there. By 12 months, the child should start waving, pointing, gesture, and babbling has to achieve. By 16 months, the child should have a single meaningful word. So what do you understand by the single meaningful word? If we ask the parent, आईला जर विचारलं तर आई बऱ्याच वेळा सांगेल की मुलाला A to Z येतं, 1 ते 100 पर्यंत बोलता येतं. The child will say mama, baba, papa. But if you ask specifically की whether मम्मालाच मम्मा म्हणतो, आईलाच आई म्हणतो, बाबालाच बाबा म्हणतो, तर त्याचा आन्सर नो येतो. So that is a single meaningful word has to be there. By 20 per month, the child should use started with 2 word phrase like pani de, jevan de, or in any children, if you feel that the previously child is able to do all the developmental milestone good, but now it is regression, you can always think in terms of a ASD. Here it is a small video I can show you. The audio is not properly clear, but I can just brief you. These are the 2 children with the normal children who are just playing with the in a bathtub. You can see the one of the video recorder has called his name, but the other child has shown interest. He had given a warm smile, good eye contact, intent for a communication, and even the child had found some object and toy, and he's also sharing with like, look what I have found. But if you see that the other child is not interested in the surrounding and no eye contact has been there. So for the screening, ideally we have a lots of screening tools. But now we all know that the MChat is freely available and it is available in all the languages also. So the MChat, I wanted to describe in a little detail. There are 20 questions with a yes or no responses. The response will always suggest the child is at risk of autism. It does not diagnose the child is having autism spectrum disorder. Each question carries a 1 point. Out of these 20 questions, question number 2, 5, and 12 carries yes response, carries a 1 point, whereas all other no response carries a significant point. So question number 1, if you point at a toy or animal, does your child look at to it? So for example, if you see that the most of the time the parents will give they can assume the different answers and they will give you just a justification. So for this question, you need to ask the child, की हे बघ वरती काय आहे. So if the child looks at your fingers, then that means the child doesn't understand what you are showing. जर वरती फॅन बघायचं असेल, the child doesn't understand it. Then question number 2, have you ever wondered if your child might be deaf? We always feel this is related to the hearing, but this is not related to the hearing. It always feel that most of the time ASD children, they are so self-occupied with the toys and anything else, they just ignore the talk or ignorance for the communication. So that's the reason. If the child is not able to just occupied with their play, you can always think in terms of the child just denying or ignoring the communication. The question number 3 is always a very important part, that is, does your child play, pretend, or make a believe? So in this example, you can see that the child has to pretend to drink from an empty cup. If you ask the mother will say की तो पाण्याचा ग्लास घेतो, स्वतः जातो, पाणी घेतो आणि पाणी पितो. But this is not the pretend play. The pretend play is always the child has to drink it from an empty cup. So or pretend to talk on a phone which is not on. Or sometimes जसं आपण लहानपणी भातुकलीच्या खेळण्या खेळल्या, that all are an example of a pretend play. Then fourth important point is that does your child like climbing on things? This just suggests the hyperactivity. As we all know, in ASD, 30 to 50% of the children might have a signs of a ADHD or a hyperactivity. Question number 5, does your child make an unusual finger movement near his or her eyes? So what does that suggest? This is just suggest the hand flapping, and you should all know the question is whether the hand flapping is a normal or abnormal. So normally also we have a hand flapping with the excitement, but that is controllable and limited for the limited person. But in the ASD children, they will doesn't have a control and it is just a repetitive movement. Then the question 6 is, it's very important that does your child point with one finger to ask for something or to get help? For example, जर आईला विचारलं की मुलगा बोटाने काही दाखवतं तर आई बऱ्याच वेळेस इथपर्यंत एक्सप्लेन करते की त्याला घरातल्या सगळ्या गोष्टी माहिती आहे, तो खुर्ची घेतो, तिथे जातो आणि डबा घेतो. But this is not the question you need to specify. The question is out of reach, whether if the anything is out of reach, whether the child denote to something by the pointing. Or sometime in ASD you can see that the child will have a hand regard, or they will have a hand on phenomena, that they will just catch the mother hand and they will go to that part of the object. Then question 7 is, does your child point with the one finger to show you something interesting? If you see that, for example, here pointing to an aeroplane in the sky or a big truck on a road. So you can't ask the aeroplane in the sky in a rural population, but you can just ask whether the child is showing car or autos on a road, or sometime also if the child is reading something, if something is interesting, the child will show to a father or mother. So the question 8 is your child interested in other children? This is very important for the social communication. As we all know, the mingling after 3 years has to be there. In this child, most of the time the mother will say, yes, my child goes to watches the child to play. So, but just seeing a children with playing is not important. That here it is the intent to communicate, the intent to go to the child should have an interest to mingle with the children. They should go and they should have a social or group play has to be mandatory. Then question 9 is here. If you see that does your child show you things by bringing them to you or holding them up for you to see? Here, main important is not to get help. It is just to share. For example, if you ask the parents की मुलगा हे सगळं करतो का, तर त्यावेळेस उत्तर असं होतं की हो, तो कारची की आणतो, बाईकची की आणतो. पण this is not something. This is just the purpose is here. The child wants to get a ride. It is not sharing some emotion. So if you wanted to share the emotion, ask the specifically की जर बाबाने काही हे काही गोष्ट आणलेली, टॉय आणली, तर चाइल्ड तो घेऊन आईकडे येतो का, तो बघतो का, आणि just observe the emotional response of a mother. Then question 10, here if you see that does your child respond when you call his or her name? That is a name response. And if you see that most of the time, if the child is occupied with some object or play, if you call his name, then the child will stop that activity and child will look behind, or child will see who is calling me. So this is just a single video I recently captured. If you see that in that video, I'm just calling the name of a child, but still the child is not able to look at me and the child doesn't respond and he just continue with the playing. Sometimes if the response to name is very specific, if I ask the mother ki tala आवाज द्या, the mother will prompt ki बघ आम्ही निघालोय, हे बघ हे chocolate घे. So that is not a response to name. So the response to name is specifically, it has to be a name response. Nothing will related to any voice modulation or something object has to be given. Then the question 11 is, when you smile at your child, does he or she smile back at you? So this is clearly example of emotional reciprocity, that whether the child is seeking. Question 12, as we already discussed, that the child of ASD may have a get upset by the everyday noises or the hyper responsiveness to the hearing side. Question 13, does your child walk? Why this question is there? Because mostly 20 to 30% of the ASD child may have a hypotonia and they may have a developmental delay. So that's the reason you should look for that. Then question 14, if you see that, does your child look you in the eye when you are talking to him or her, playing with him or her? This purely indicate an eye contact. The eye contact has to be consistent enough that so minimum of a 3-second eye contact has to be there. In ASD, there may be a fleeting eye contact or there is no eye contact can be there. So question 15 is, does your child try to copy what you do? So it means, for example, waving a bye-bye or clap or make funny noises when you do. So usually the 9 months to 1 year, if you just ask the mother, bye हे करतो का, the mother will give you physical prompt. So just do a bala tari wajo or bye kar. But after 1.5 years, if the mother does not need a physical prompt, it has to be spontaneous with the verbal command only. Question 16 is, if you turn your head to look at something, does your child look around to see what you are looking at? So it just means that whenever the mother and the child is playing and somebody is coming inside the room, the mother look at it, but the child doesn't bother about what the mother is looking or whether she's present or not there. Then 17 is, if you see that here, does your child try to get you to watch him or her? So just it is just to have a praise, informants, or the appreciation that child is receiving. The 18 question, understand if the child understand when you tell him or her to do something without any pointing, like हा पेला आहे तू तिथे टेबलावर नेऊन ठेव, without any pointing, if you are just commanding, and the child should understand. So here three points has to be mentioned. One is the hearing capacity, like the listening capacity. Second is the understanding about the command, and third is the following the command has to be mentioned. Question 19 is, if something new happens, does your child look at to your face to see how you feel about? So this is just about just to understand the what is your emotions, that is emotional reciprocity for this child. So 20 is, you all know that the most of the time 2 to 3 years of age group, most of the time the child will have a movement activity, just jumping and swing also. So if you have an MSHAT, how do you read it? If the score has come to less than 3 in a more than 2 year of children, then there is no follow-up has been required. But whereas if the child is having a moderate, that is, score is 3 to 7, so ask the details about what is the screen time, what is the whether the child is having nuclear family or limited social interaction is there. And here, advise the parent to encourage more and more social interaction and then repeat the follow-up with the MCHAT RM. But whereas if the score is more than 8, so just bypass the follow-up and refer the child for the detailed evaluation. There are many psychometric evaluation which are available, that is CAR test or ISA certification, INCLAIN test will be there, ADI test will be there, or many tests which are there for the child behavioral checklist also. So why the ASD diagnostic and early intervention indication is important, as we all know, in Hollywood, in Bollywood, in Netflix dramas, in Hindi dramas, there are many personalities or the many characters which are playing upon ASD. So the key message for today's presentation is, as we all know, the ASD prevalence is just going increasing. All children should undergo screening for ASD 18 to 30 months of age. The hearing screening is mandatory in every child with a speech delay. And here the pediatrician play a very important role in a clinical screening, diagnosis by the detailed history and examination. Early referral and the intervention is must. And the most important, I just wanted to help you, don't be in a hurry to label the child that the child is having ASD or something else. Just take detailed evaluation, give some social interaction, make the children have a better environment for stimulation, and then you can have a proper evaluation, proper follow-up, and then you can. I hope this after this presentation, many of the pediatrician will able to screen in a more proper, more detailed way. Thank you so much.
Wonderful, Dr. Sarika. I'm so happy that I know it was a mammoth task to finish in this 15-20 minutes on this big topic. I'm going to just give you first thing I wanted to be everybody to understand from Dr. Sarika's message is, please, please, please don't label the child. At this early age, the parents are they are also, I always say, the mother, when the child is 18 months old, the motherhood is 18 months old. So the mother is literally, she's also that small. So for that mother and diagnosis of autism, and you label the child, and then the Google goes in and Google crashes the mother like anything. So Sarika, I'm very happy that you don't want to label, because you have to work on the whole child and not the diagnosis itself. Second thing is, I'm just going to add only two things about it. Can we diagnose before 18 months? Because parents are coming at that age. My unfortunate diagnosis earliest is 9 months, and I was unable to tell it to the mother. And we have to be very careful in telling the mother that yes, we need to look at the social communication of the child. So, and the earliest possible, as you rightly mentioned, is a lack of social smile. And the first, there is one of the very interesting point in the literature. At 7 day, can we go back and diagnose the child's autism? Undifferentiated cry. When the child is unable to tell when I'm crying for breastfeeding and when I'm crying for handling me, that's social. And if the child, that is the earliest way we can diagnose autism in these cases. So, but better not diagnose, because that's another, but we can look at it into that perspective. One of the tests, CSBS, if we can go on internet, we easily available, that can be used in infants less than 18 months. And the best test is the IIP test, the TDSC. Use TDSC to use diagnose autism. It is not very difficult. Just you have to look into the autism way. I think with the time permits, Sarika madam has done a wonderful job, especially when she went through the whole MChat, and it was a learning point for me the way she was explaining each and every point. Thank you again for that point. What is most important takeaway from the pediatrician? Please have high alert. Autism is a bigger pandemic than COVID, and COVID kills, autism suffers. So just look at it into that way. Keep your eyes open, keep your ears open, look at the child in a different way. हो जाएगा, हाँ, wait करो. नहीं, that is not going to happen, because, and the last silver lining to this early intervention is there is something called as a emerging milestones. I'm proud to say that I failed 3 times with the diagnosis of autism, because the parents worked on that milestones, the milestones emerged, and my diagnosis of autism was wrong. So this is a silver lining to the early diagnosis. I think we have less time. Over to Dr. Sandeep and the next speaker. Thank you, Sarika, for a wonderful 15 minutes ride.
Thank you so much, sir. It's really difficult to finish it all the ASD
Yeah, I
in
know.
a 15,
It's
20 minutes.
wonderful.
Yeah. Should we go ahead?
Thank you, Sarika ma'am, as well as thank you, Sunil sir, for such a wonderful explanation. Definitely, we pediatricians will try to at least screen and at least implement MChat in our OPD practice. That is most important. So, moving to the next topic now, I request Smita Bajaj madam to start her topic. That is a digital screen exposure as well as developmental delay. So, another very important topic.
So is my screen visible?
Yes, ma'am.
Yeah, I'm audible also.
Yeah, ma'am.
So, okay. Good evening all. At the offset, I'd like to thank Maha IIP, especially Dr. Renu Borarkar madam, for giving me this opportunity to present this topic. So the topic of my presentation is digital screen exposure and developmental delay. As we all know, today our children are living in the new reality, that is the digital village. Children are exposed to screens at a very early age, even before the age of 1 year, which parents don't expect at that age, and they don't detect also. So mobile phones, tablets, and smartphones are now, they are permanent.
Hello.
फ्रीज झाले का यू प्लीज द व्हिडिओ क्लोज करा आणि नंतर बोल स्मिता तुझा व्हिडिओ क्लोज कर
Yes.
वी आर नॉट एबल टू हिअर यू मे बी
Okay, ma'am.
इंटरनेट प्रॉब्लेम
Okay.
Yeah, we can hear now.
and now we can hear or you can just yes the video can be closed
Okay. Yeah. Am I audible now?
Yeah.
yes
Okay. So I was telling about understanding digital screen exposure. So digital screen exposure is the time spent on digital devices. So it can include educational as well as environmental entertainment content. It is measured in hours per day, and content quality is most important. Like what content and with whom the child is watching, that is most important for digital screen exposure. So what does the recommendation says? Globally, the American Academy of Pediatrics and the WHO recommends under the age of 18 months, there should be no screen time except for video chatting with family. Between the ages of 18 to 24 months, only high quality programming introduced and discussion. And between the age of 2 to 5 years, the limit is again to 1 hour, that to quality content, the parents and or caregiver co-watching the thing. So but this is what the recommendation says. But if we have a reality check, a global meta-analysis which was just conducted shows that only a minority of children in this group actually meet these guidelines. A recent Indian study which was conducted in 2025 in Kerala, it included it was the objective of the study was to assess the screen time of Indian children. So majority of children in the study exceeded the recommended screen time. The screen exposure started very early, even before the age of 2 years, and most of the children were using it during meals or before sleep. Mobile phones were the most common devices used, and children with high screen time had speech delay, behavioral issues, and sleep problems. The another study which was conducted in Japan, it was conducted in 2023. It was a landmark study, included 7,000 children, and it also revealed that the screen exposure occurs in 20% of the patients. The screen exposure was very early before the exceeded the WHO recommended maximum, which was a striking finding with real developmental implications. So despite clear guidelines from AP, IAP, the gap between the recommended and the screen time continues to widen. So this is a time when developmental pediatricians, the general pediatricians and families should start thinking. So how does this screen time affects the brain? So as we all know, just now sir also discussed, there are critical windows when the child is developing. So first 5 years is the critical period when the maximum brain growth is occurring. So between birth to 1 year, sensory and motor foundations occurs. Between the ages of 1 to 3 years, language and social bonding occurs. And above that years, there is executive functioning. So if the children are exposed at this critical period to their neural connections may get hampered and they are not stimulated the way they should be. So be alert that children are not exposed to screen during this critical period. So hands-on play, neural connections, fine motor skills, while passive screen displaces these critical developmental opportunities, causes delay. So how can screen time cause delay? The mechanisms there are different mechanisms, but the most common is they cause displacement of interaction. Due to excessive screen time, there will be reduced caregiver interaction. So the critical thinking, abstract thinking, everything will be reduced. There will be reduced exploration. So cognitive delays may occur. Again, sedentary behavior may lead to obesity, and again, physical activity will be reduced. So these are the three basic mechanisms through which development of a child. So it can replace real life situations. In the fast moving screens by fast changing visuals, they can cause overstimulation of developing brain. They can reduce attention span. There will be lack of social learning pathways. Dopamine, what happens in neurobiology is there will be excessive dopamine release in the reward pathways, which can act as an addiction. So screen can act like addiction like behavior. It can alter the prefrontal cortex. It can cause reduced impulse control. It can impact on learning. Excessive use is linked to reduced white matter integrity and weaker frontoparietal connectivity, affecting the inhibitory control and attention. In language, as we all know, language develops after we socially interact, after we see, after we get reciprocal communication from someone whom we are connecting. So in screen, the children only have one-way communication. They are continuously watching. So language and social communication are the most common things which are delayed due to excessive screen time. So there will be poor vocabulary development, reduced comprehension skill, and increased risk of speech delay. Cognitive impairment may occur due to reduced attention span, the continuous overstimulation, which can also impair memory and learning. So as there will be lack of abstract thinking, lack of exploration, there will be reduced problem solving skills and reduced executive functioning. Motor delay can occur because there is reduced physical activity, fine motor coordination, and increased sedentary behavior, which can also lead to poor posture and muscle tone. Of obesity. So sleep disturbances are also very common in children who look after the screens just before sleep. So blue light suppress, which can cause delayed sleep onset, recallings, and daytime irritability. So there is a new term called visual autism. It is an emerging concern. So although it is not classified into international classification of diseases, it has something like autism-like features in which children who are more exposed to screen can have delayed eye contact, they can have delayed speech, they can have delayed social communication, and reciprocal behaviors can be there. So while not an official diagnosis, the phenomenon highlights the profound and potentially reversible developmental shift. If we act early, this can be reversed. If it is due to genetic or some other reason, it may not reverse. So the landmark study which I discussed before, the objective was to find association between screen time at 1 year and developmental delays at 2 and 4 years. So the study concluded that greater screen time was associated. That is, the children with more than or equal 4 hours of exposure are nearly 5 times more likely to have communication delays. They are likely to have 74% more chances of fine motor delay. They are twice more at risk for development of social skills. So the more it is said to be dose dependent. More the screen exposure, there are more chances of delays. Then the second study, which was conducted in 2019 at Canada, the aim of this study was to see the question was whether screen time leads to a developmental delay or developmental delay time children are more exposed to screen. So the study concluded that high screen time was associated with poorer developmental outcome, and while the poorer developmental scores did not predict the higher screen time. So, in short, the screen time always preceded developmental delay in majority of the studies. So if we see the key comparison till from the research available, so all of them concluded that screen time causes delay. It can be dose dependent delay. And again, one Indian study which I found, which was recently conducted in 2026, it studied about parental behaviors and screen time. So the study concluded that there is 40% exposure of 48.4% of screen exposure at 1 hour can lead to 48.4% children had screen exposure 1 hour before bedtime. 48% device use at all meal times. They showed temper tantrums, and parents find screen exposure uncontrollable. So reported speech delay was 5.7% in this recent Indian study. So why do mothers give baby the screen? So it can act as a babysitter, or it can be a modeling as a modeling. So Boy et al. Found that parents often use screen to pacify children or as babysitters, and 48% of them used it during meal times. So the most important question is, for most of the studies, they concluded that there is an association rather than screen time causing the delay. Screen time as such for cause of delay, further studies needs to be concluded to come to a conclusion, as there are many other co-founders also, such as family dynamics, parental styling, and socioeconomic factors. Am I audible clearly?
Yeah.
Okay.
Perfect.
Yeah. So what we can do? So beyond the screen, we need to target fostering healthy development. So what all things a parent, a developmental pediatrician, or what as a society we can do? So there is the power of early intervention if we detect early, because the neuroplasticity is maximum in the initial 2 years, say initial 5 years, when the brain is at maximum growth of potential. So if we detect early, we target services at an early age, we can catch the children, and many of the things such as like virtual autism or children who are lacking can be reverted back. Then role of parent and parent control. The another study I found, it was conducted again in India. So they screened through DDST, and they found that parents who had high control, clear rules, who were co-weaving the content with the children had better outcome rather than the parents who had low control or moderate control. So children whose parents use screen mindfully are more likely to develop healthy digital habits themselves. So what are the strategies the parent can follow? We need to have a balanced digital environment. We can set screen-free zones. We can use co-weaving and dialoguing whenever we are watching something or whenever the children are watching something. And high quality content should be our aim. Because as we all know, we cannot completely eliminate screen. Now this is a digital world, so we need to think of strategies which can put a healthy habit of digital viewing in children. So we can read daily reading around builds vocabulary, listening skills, outdoor exploration, outdoor plays, or some play dohs and all for early toddlers can help. Creative arts again has got fine motor control which can help, and social play which will help the children to develop socially and emotionally. So again, there is a term called digital detox protocol. So in this, the children are removed from the screen gradually. The detox protocol is done. The interaction is increased from the parents, and reassessment is done to see if the children are really moved away from the screen or not. So the basic thing is we have to establish clear limits. We have to designate screen-free zones. We have to promote alternatives and use screen mindfully. So the path forward is the future of childhood in a digital age is not going away. Digital media is not going to go away. So our aim as a developmental pediatrician is not to eliminate screen, but to harness their benefits while actively mitigating developmental risk. So we have to, the challenge is building a framework that works with and not against the modern family life. So it's not about elimination, but it is the goal is mindful, intentional use that fits within a reach of developmental environment. So quality of the content is most important. Prioritize human interaction above all. Choose interactive or passive content and set predictable screen-free windows daily. So pediatrician can have for the message for pediatrician would be we need to routinely screen, because now now digital media is everywhere. Each and every house is going to have digital devices. So we need to follow protocols of routine screening in our busy OPDs. Tailor-made resources provide AAP family plans so that children understand that the parents understand that they should not expose their children to media at early age, and early referral whenever you are in doubt. So the long-term vision will be first will be prevention, then founding of foundational skills and equity and access for all children regardless of their background to have access to developmentally enriching environments and early support. So the key takeaways from my talk will be screen exposure is increasing rapidly, which we cannot avoid. Excess screen is associated with developmental delay. As of the present studies are showing them rather than a cause for developmental delay. So language and social skills are the most affected due to screen. Early exposure is more harmful because the brain is rapidly growing. Parent-children interaction is most important, and it is the only remedy which can avoid all these delays. And pediatricians follow an important role for counseling of the family. So thank you. Let's build healthier development environment together. Thank you.
Wonderful, Dr. Smitha. Again, a big topic and a short time. So
Thank you.
I'm feeling that I'm attending a whole conference in 1 hour. So I'm so happy about it. But about this particular topic, the take home for from all of us is first thing is we are not discussing about the parent screen time. And let's start working on that. Children are copycats. Children learn
Yeah.
from copying.
Yeah.
So can we reduce the parent screen time? So that is first question we need to work upon. Another part of the screen time which I just wanted to highlight over here, everything is becoming from the, we used to do the we used to look at the Ramayana and Mahabharata on TV episodes, 45 minutes for our sitting time. Now, thanks to Instagram, our sitting time is 45 seconds. So that is another thing which is going into a very wrong direction. So I tell people are very interesting because we cannot avoid screen. Step one, from mobile, move to laptop. From laptop, move to TV. In mobile, it is internalization. In TV, the क्योंकि सांस कभी नहीं होती, it remains in the TV screen and it doesn't go inside. So आप what you can tell the parents कि पहले आप एक करो कि सब मिलके टीवी देखो, मोबाइल कम करो. One of the possible. Mobile, there is one more thing which I wanted to add to Smita's very good presentation is that immediate gratification effect. I
Yes.
won. So I win one more. So I get a tendency, and it is so fast that they will start expecting it from the teacher, and we teachers had to go with the class, and so now they are labeled as there's a virtual autism. We say there's a virtual ADHD also because of this screen. The children learn to go faster in that time. And that fastness goes to the extent that they want to, the way they change the mobile screen, they want to change their spouse. And that is Jane Alpha. I think I'll stop on that moment. With a wonderful presentation, we'll go ahead with the
Thank you,
next
sir.
part.
Thank you.
Yeah, thank you.
Thank you, Smita ma'am. Thank you, Sunil Godbole sir. It was really a very good presentation. Definitely, we pediatricians are now basically a family physician for the families. For as far as children are concerned, we have a definitely major role. We can control this, or we can advise properly. So I request all the delegates, they can type their questions, and we can have a questions at the end. So now I request Meenakshi madam to start her presentation, early detection of motor delay in infancy.
Hello. Am I audible now?
Yeah, wonderful.
Yeah.
Thank you so much for inviting me to speak. I am so honored to be part of this talk. And बोलेंगे ना बड़ा मुंह sorry what but I am in front of so many pediatricians, esteemed professionals. So please excuse me, and you can please feel free if I make any mistake. Please go ahead and discuss with me as well. My topic for today is early detection of motor delay in infancy to suspect cerebral palsy. And when exactly, as pediatricians or as doctors, it will be nice to refer for early intervention. We have been speaking about early interventions in the last two talks also. And it is really important to understand that the development will happen maximum. The potential is there between 2 to 5 years of age, as mentioned. And therefore, it is very important for us as therapists to utilize this time and get the intervention started. So, really speaking about motor delay, broadly, we can classify it into gross motor delay and fine motor delay. But also, as we go ahead and really define motor delay, we are talking about age-appropriate milestones, which whether or not the child is achieving that or not. And it can be presented in an isolated manner, or it can be part of a bigger, maybe a syndrome or like a global developmental delay. It could be some metabolic conditions. And it's very important, again, to have a diagnosis where pediatricians often come in handy. They are the first source of contact here. So when we are talking about delay, we normally talk about two standard deviations from the normative data. And still the normative data, it is a wide range. So we will go through it one by one. If there are any, deviations from the standard, then that will be considered as a red flag and it will need further intervention. Talking about the classification system, as a therapist, I know that we primarily classify this motor delay into three ways. When we are talking about the international classification system, we are talking about the neurological disorders and the diagnostic codes, which mostly the doctors will label it depending on what they're seeing, what are the signs and symptoms. But as therapists, mostly we look into the GMSCS levels, which is the gross motor functional classification. This is a system which is, classifying the function of the child as per the age, and you can label it between 1 to 5. 1 being more and more independent, and 5 being more and more dependent. And this can be categorized all the way, even from the age of less than 2 years, and you can keep going all the way till adulthood. WHO ICF framework, which is also equally important for us as therapists, is where we are really categorizing it and breaking it down into, you can say, almost like puzzle pieces. And that gives us the opportunity to discuss what can the realistic goals be for this family or for this child. So when we talk about that, one is body structure and function, where we are actually evaluating the biomechanics, the anatomy of the body,
what are the functions which are present, where is the struggle. Then we are, based on that, giving it some activity limitations and saying, okay, so let's say there is a gastrosoleus tightness. The limitation of the activity would be then the child is toe walking, or is not able to achieve independent walking because of this. And the participation restriction because of this, let's say the child is not able to go to school or not able to play football in school, that becomes at a more participation level. And as a family or as a child who's affected with cerebral palsy, I think participation is the most important area that should be targeted. We are looking from a rehabilitation perspective where they can be integrated into the system. Not just कि okay, let us say अभी gastrosoleus tight है, हम लोगों ने उसको lengthen कर दिया या botox दे दिया, but are we expecting any change in the outcomes? Are we expecting better gait patterns? Is that gait pattern then going to allow this child to probably, let's say, go to his classroom on the first floor, climb up the stairs, or play football outdoors? So this is what we look at. So coming to the normal milestones and what could be the red flags and how early one should really refer. We are talking about, so I see babies here from high-risk infant babies in the NICU, and as a developmental therapist, I have already started intervention for high-risk infants there, so that is my starting point. But we also ask high-risk infants to come in for follow-up, and for us there are some timelines in which we really want to monitor the child closely. So one is the preterm age and then the term at 40 weeks. This is our starting point. It gives us the baseline of what really the child is going through. It might be in an IPD setup or an OPD setup. But then the changing point in our evaluation really comes at around 3 to 4 months. This is not only when we are looking at head control, but we are also looking at a lot of other things that start developing before 3 months. So whether they are starting to look when they're lying down on their stomach, whether they are bringing their hands in the midline, whether they're trying to really, bob their head when they are placed in prone position. Are they able to tolerate prone position for a few minutes? Are we seeing a distinct, preference for one hand over the other, or one limb or one side or more than the other? Also, from a general movement assessment perspective, at 3 months, we are looking for fidgety, something called as fidgety movement, which I will come to in some time. At 4 to 6 months, again, we know we are looking at rolling. We are looking at rolling on both sides. We are looking at the pattern of rolling, whether it is in a flexion pattern or whether they are using some sort of extension thrust or an opistotonic posturing, which is creating the rolling. We are looking at how frequently it is, happening bilaterally, or is it one side more than the other? So these are the small discrepancies that we are looking at. At 6 to 8 months, we're looking at sitting independently. And what is again the pattern of sitting? Are we looking at is it sacral sitting? Is it ring sitting? Do they prefer to be in W sitting? So we start looking at those, and it gives us more hints into the biomechanics. If it's W sitting, are we looking at the gluteal function? Is there weakness in the abdominals? And that's what our starting point for assessment becomes. At 8 to 10 months, we are looking at crawling. Again, they go from sleeping on their stomach to bunny hopping forwards, and then into the primitive pattern of crawling, and then finally into the dissociated pattern of crawling. Looking at all of these, and then eventually 10 months later, we are looking at whether they are pulling to stand, whether they are walking along furniture, so they're cruising along furniture, and then finally whether they are walking in a reciprocal pattern. So what really would be the red flags? We were talking about, having 2 markers less. So if we are looking at persistent hypotonia or a marked stiffness. So we are seeing any variations in tone. Again, this could be generalized or this could be very focal. It could be only maybe in one limb. It could be on one side. It could be central as compared to peripheral. This is something that is of concern. We are talking about poor head control after 4 months of age. Definitely, we are looking at a delay in motor milestones. Persistent fisting, after the age of again 3 to 4 months is considered as abnormal. We should start seeing, opening of the hand and fingers latest by 2 months, 1.5, 2 months of age. Opistotone is abnormal arching. Sometimes it is because of, other conditions like GERD, or, they will have their head only turned to the right side. So these are some of the difficulties we are thinking about. Okay, it may not be just a motor concern. It might be something internal going on, and it's important to differentiate. Feeding difficulties or a poor suck again. We're talking about red flags from 6 to 12 months of age. So when they're not sitting independently by 9 months in a ring sitting position with, using hands to play, they should be able to leave. They're not really guarding their hands down and pushing against the floor. They are able to play with both hands by the age of 9 months. Absence of weight bearing on lower extremities. When you put a child in standing, you will see a reflex pattern where they are kind of loading their feet and almost bouncing. It's almost like a little jump when you place them on their feet. If that is absent and they're falling downwards or creating a sort of scissoring posturing or an extension thrust, again, this would be considered as abnormal. Early hand preference before the age of 12 to 18 months suggests asymmetry and some sort of unilateral weakness, which should be looked into. Poor trunk control with inadequate postural reactions. So we see this sometimes in simple, recently I saw a case with torticollis. And the only issue that the mother came was, oh, we have done the ultrasound, we have gone to so many doctors, and all we are seeing is this torticollis. The child was 6 months old, but did not have any postural reaction. So when I was tilting the child to the side, the head was not moving with the body. There was some level of hypotonia, and that was completely missed. So we were looking at actually some sort of, it was again a red flag for general motor development. At 12 to 24 months, not walking, again by 18 months is considered as a delay. But we don't necessarily want to wait, till 18 months. So if we are seeing at 10 months that the child is not pulling to stand, or there is some sort of abnormal biomechanics which is playing while the child is trying to do a pull to stand, or we are seeing some discrepancy in the gait pattern, it's very important that we start working on it early. Every day, every week matters. It could, mean a lot to kind of whether they will achieve the function or whether they will be dependent. Persistent toe walking. A lot of cases of late have been coming with idiopathic toe walking. There has been no real reason behind it, and it also fits really well with the previous two topics regarding autism. We are looking at whether, as therapists, this is a sensory concern which is causing toe walking, or whether it is really a pure motor concern. It could be a mixture of both. Is it sensory-led motor disorders or motor-led sensory disorders? So it's very important to differentiate between this and accordingly refer for therapies. Our aim, our goals, and our approach towards therapy drastically changes between the two. Scissoring posture, again, suggestive of lower extremity, increase in tone, and again, something where we will need a multidisciplinary approach. Loss of previously acquired skills, this is a definite red flag. We might suspect some neuromuscular disorders, any kind of regression is also a red flag. So cerebral palsy, as we all know, it's a non-progressive disorder. But however, there can be a lot of secondary involvement, secondary musculoskeletal concerns, secondary respiratory concerns. which manifest as the child keeps growing up. Therefore, it's again equally important to start with early intervention. So when we talk about the evidence-based risk factors, we are definitely talking about someone who has had a complex medical course in the NICU. That's majority of the cases we are seeing very low birth weight, extreme preterm, but also someone in their early 30s also present with a lot of motor delays. Infections, neonatal seizure, history of neonatal seizures, birth asphyxia, RDS, and so this kind of becomes our population which we want to consider following up on whenever they are coming in for the baby checkup or the high risk infant programs. I think it's really important to have that kind of a system in place where the pediatrician is then able to make the multiple referrals to the relevant teams early on. So the early detection tools, what is really done, how do we really use our approach apart from the standardized assessments where we are looking at reflexes and tone and range of motion, deformities. There's also something called a general movement assessment, which can be, so there's a lot of studies which say that it is more accurate used in this age group, which is 0 to 5 months of age. It's more accurate than an MRI of the brain. It is, the onset of fidgety movements, which comes at 3 months, becomes the primary, sign on whether the neurodevelopment is happening appropriately or not. It can be a strong indicator. And this is something that is commonly followed. Apart from that, we also use Hammersmith Infant Neurological Examination, which again looks into key components of what we spoke about, whether there's midline, whether midline crossing is there, whether hand to hand, foot to foot is there, whether rolling is there, bobbing of the head is there, and all those little 26 items that it is broken into. Apart from that, of course, there's neuroimaging, and then there is developmental screening. There's a lot of different tests out there. Denver Bailey's assessment is a very standard. T-body assessment is something else. There is STIMP, which is often used also for neurological examination. So these help us with really putting it down in a standardized format and having a number to then be able to work with. So really, what do the international guidelines recommend? The AAP recommends that there should be early screening and all well child visits, which are equivalent to where they come in for vaccination here. And there should be a standardized developmental surveillance which should happen that includes, like, for example, let's say hip surveillance in someone who is spastic or absolutely low tone. NICE guidelines also go with the same thing. Apart from the the vision and the hearing assessments, there should be a neurodevelopmental assessment which should be done. And we are talking about now the absence of fidgety. What does that really mean? When do we really start intervention as therapists? So I already said the starting point is never too early. As soon as we think that this baby or this child belongs in this pool or population where they are at a high risk of developing some sort of developmental delay, it is very important that we start our intervention, depending on whether we want to use a preventative approach, whether we want to use early intervention and improve certain things, whether it is simply developmental care that we are looking at and teaching parents, or then we are going in for rigorous intensive therapy or early intervention programs. So any absent fidgety movements at 3 months of age, or that is 12 weeks of corrected age, HINE scores of less than 57, any abnormal MRI findings, if you've seen any HIE, or you are seeing any abnormalities, there's a bleed, there's a stroke, any persistent abnormal tone, this is where we would want to immediately start with therapies. Even other investigations can happen. You can have that parallelly, but it's very important to start with early intervention immediately. So these are again the immediate referral indications, any red flags: high risk infants, delayed milestones of more than 2 months, abnormal tone or posture, and if there are any parental concerns that, what, my other child developed this at this age, but I'm not seeing the sibling develop this. So I think it's very important to kind of take that into consideration, the parent's experience as well, give us a clearer picture. So role of physiotherapy, again, what I briefly spoke about, it is not necessarily that we are only working to promote motor development and prevent contractures. We are eventually looking at improving function and improving participation. We are looking at rehabilitating not just the child, but also the family in looking after this child. This is not something that is going to go away. So how are they going to cope in school? How are they going to walk? What are the special aids that they may require? How independent are they going to be? What can they play? Are they going to have friends? So all of this, the 5Fs, they become very, very important. Family, function, fun, all of that becomes really important. Early intervention approaches, there are so many different approaches available, and usually it's a mixture of all of these that you will see in any single session that we conduct. Neurodevelopmental therapy, there is CIMT, which is constraint-induced movement therapy, there is sensory and motor integration programs, family-centered care, and teaching home-based protocols, and task-specific or function training. So again, I think we've kind of covered this, why early intervention really matters, why early referral matters. It is to bring out the best outcome possible, to be able to detect and pick up something really early on before the damage is done, and to try and make the most out of the most important time. So just to go through the algorithm of how we can refer, or what is the sequence in which things would flow. When we see a red flag or we identify a delay, you can conduct screening tools, or you can be referring it to someone who does it, but also make an immediate referral to the physiotherapist or to the occupational therapist or to the therapy team, simultaneously consulting with whether they need a neurologist, a geneticist, or a developmental pediatrician, and really start the intervention early. So really the takeaways are: don't wait and watch. Let's pick up the signs early. They are really, really subtle. Screening tools are very important. It helps us to document what exactly is going on and where they're going in terms of progress. Starting therapy early is absolutely important. And I think parental concerns are absolutely valid. Their goals are equally important for all of us. So motor delay whispers before CP screams. Let's catch it early, act fast, then doubt. Every week counts in neuroplasticity. Early detection and immediate referral to the therapy team may represent the standard of care for infants with motor delay. Thank you so much.
Thank you, Meenakshi Madam. Again, wonderful, wonderful. And I first congratulate Maha IP for getting a person like Meenakshi Pirwani on our platform, because we pediatricians talk among ourselves, but we don't know what is going on the other side. So the therapist, we always say refer to the therapist, but वहाँ पे क्या होता है? We don't think, and that is where I think Meenakshi Madam has given us a quite a good eye opener. We had less time. We are already past time, so I'm going to just give a one clear thing is we must be. There is a very quick understanding tutorial. If we miss motor development delay by 6 months, we are doing something wrong. If you miss by 12 months, it is something really dangerous. So first birthday, and if you are missing motor developmental delay, we are having something wrong. We miss by 18 months or maximum by 20 for autism, we are doing something wrong. We are missing some speech delay and speech issues by 30 months, we are doing something wrong. If we miss ADHD by 5 years, we are doing something wrong. And if we miss learning difficulty by 7 years, we are doing something wrong. Just this is a quick reminder I want everybody to remember. Now coming back to Meenakshi madam's job, what is pediatrician's job? तुम्हाला कळलं असेलच मॅडम मस्त अवघड अवघड शब्द बोलत होत्या आणि आवर जॉब इज दॅट ट्रांसलेटर्स जॉब व्हाट द पेरेंट्स कम टू द डेवलपमेंट मीनाक्षी मैडम बहुत अच्छा बोली मैंने बोला क्या बोली नहीं वो समझ नहीं पाए so the pediatrician's job is convert their heavy jargon words into the parent friendly words. So madam has given a hint. She was talking of the gluteus, for example, kuch to gastrocnemius, and the ultimate is the child able to bad? ते बूड हलवू शकतं का? हा जो pediatricianचा message आहे. I think we need to convert the therapist language to the parents, and that is the biggest role our pediatricians is there. Because for the parents, the most of the time the therapists are द क्लोज रूम थेरेपिस्ट. उनको अच्छा नहीं लगता कि अपने बच्चों को बाहर कुछ दिखे तो क्या होगा, बच्चों पे नजर लग गई. बट द पेरेंट्स वांट दैट थेरेपी टू बी टेकन होम, एंड दैट इज द ओनली टाइम द सक्सेस विल हैपन. अगर 30 मिनट में अगर बच्चे में चेंज होता तो स्कूल इतनी 6-6 घंटे की हम बर्बाद क्यों करते टाइम. सो माय रिक्वेस्ट ओवर हियर इज फ्रॉम द थेरेपिस्ट, take a home program. From the home program, convert into the daily natural activity. Then and then only the child will succeed. Child will be doing very well. And as madam has rightly said, I think I will end today's session from my side. एक योगायोगाने पुण्याहून संभाजीनगरला जाताना एक मी बोर्ड वाचला होता. लवकर निघा, सावकाश जा आणि सुरक्षित पोचा. So that is the message of early intervention. So go slow, start early, go slow, continue. आणि संभाजीनगर तेवढा वेळ लागतोच. And then you reach. Okay. Thank you, Meenakshi, again, and all the wonderful ladies
So
who
much,
did
sir.
a big job. Thank you. Thank you. Yeah. Dr.
Thank you, sir. Thank you, Meenakshi madam, for really wonderful talk, and all the topics were really good, and all the speakers were really great. Now I request our Sanjay Nathu sir, the chief of our scientific committee, to give closing remarks about all today's talks.
Yes, so very wonderful session today. We planned this session on developmental pediatrics basically towards the last end of this month, because we'll be marking the Autism Awareness Week and Autism Awareness Day next week. So we thought we should have a session near to that, and that is why this session was planned. All the ladies, Dr. Sarika, Dr. Smita, and Dr. Meenakshi did a wonderful job. I think they gave us very good takeaways, which we will be hopefully using in our practice. And Dr. Godbole sir, as usual, the expert summing it up and giving us good inputs, helping us make sense of all these issues in our daily practice. So thank you, Dr. Sarika, Dr. Smita, and Dr. Meenakshi, as well as Dr. Godbole sir, for that wonderful session. Thank you from my side. Back to you, Dr. Sandeep.
Thank you, sir.
Thank you,
Thank
Dr.
you, sir.
I request Praveen Godbole sir.
Praveen Gokhale.
Praveen.
Gokhale sir.
Gokhale,
Yeah.
sir.
Praveen,
So-
sorry. Praveen Gokhale sir. Sorry, my mistake. Praveen Gokhale.
So, yeah, I think it has been a very engrossing session. And as Dr. Nathu said that we had been planning this for a long time to have it in the anyway. The this topic was very relevant to what we are celebrating this month. And what gets left out is the next step. That is the we all will think about developmental part, but about the intervention part and the physiotherapy part, we know very little. So today we got a measure of everything together in one piece. As Dr. Godbole said that he felt like he was attending a mini conference, and that serves the purpose that within a short period of time, our young voices, expert wisdom, has been able to deliver the message to those of the attendees. So I thank all the people who have been there today to attend this program. I thank all the office bearers and MahaAP team for thinking of such a wonderful topic such as Young Voices, Expert Wisdom. And so I hand it over to Dr. Sandeep Karle. I thank everyone for being a participant today. And Dr. Karle can take the program to conclusion till we meet again in the next month, last Thursday of next month.
Thank you,
Yeah.
sir.
Yeah, thank you. Thank you all the delegates, first of all. Then I thank all the speakers as well as Maharashtra IP team, everyone. And thank you our support team from Maharashtra IP, Pallavi ma'am. So I think I declare we are closing the scientific session. Thank you all. Yeah.
Thank you all, Dr. Smita, Dr. Sarika, Dr. Meenakshi, and Dr. Sunil sir, for an excellent presentation and also the expert comments. And thank you, Dr. Karle, for conducting the program successfully. And we will have more in the near future according to our scientific team. So thank you one and all, and good night.